Good evening. My name is Candace Cousins-Hopkins, and I'm the Assistant Director of Marketing for Special Events here at St. John's Riverside Hospital. For those of you who have joined us for the last two webinars, thanks so much for joining us again. And for those who are on for the first time, welcome. Today's presentation will be focused on pain management, which is a very popular topic as many of us will experience pain at some point in our life, and we may not know how to manage it outside of physical therapy or pain medication. And so we feel this is a webinar that will be very helpful and informative to all of our viewers. Before I introduce our guest speaker, I wanted to acknowledge our partners, Sally Pinto, who is from the Yonkers, Newark, the neighborhood naturally occurring retirement community that is under the umbrella of the Yonkers Office for the Aging and Westchester Jewish Community Service. Newark provides programs, activities, and services including nurse and resource specialists to seniors 60 plus living in Northeast Yonkers. Z Baird is from the Yonkers Public Library, which has 3 locations: Riverfront, Will, and Crestwood. Please visit their website for hours of service, free programs, downloadable books, streaming movies, and more at www.ypl.org. Now I would like to welcome our special guest, Dr. Stephen Erosa, who is a dual board certified pain physician who focuses on rehabilitation and advanced interventions to help manage chronic pain. He is currently practicing at St. John's Medical Group at the Boyce Thompson Center in Yonkers, and he's a dedicated physician who aims to provide treatments that have long-lasting effects. And so we are so happy that he's with us today. And so Dr. Erosa, whenever you're ready, please take it away.
Thank you, Candace, for the introduction. I'm glad to be here this evening, and thank you everybody who has come out to listen and learn a little bit about what we can do at St. John's Medical Group in the interventional pain office to help you with your chronic pains or loved ones that may have be suffering from pain in the neck, back, arms, shoulders. I am, just to introduce myself a little further, I'm a physical medicine and rehabilitation doctor. I'm a physiatrist. And for those of you who don't know what physiatry is, it's essentially a medical specialty that focuses on restoring function, improving quality of life in patients with chronic conditions. So in a nutshell, patients that have issues like spinal cord injury, traumatic brain injury, patients who have chronic heart conditions that have had surgery and are somewhat debilitated, the doctors that take care of them and work on cardiopulmonary rehab, spinal cord injury rehab, manage those cases are physiatrists, and sometimes an unknown specialty, but may have touched your life in some way or another through a relative or something of that matter, regarding orthopedic care post-operatively with knee replacements and things of that nature. And the specialty that I focus on is interventional pain management, interventional spine care, which essentially makes me an orthopedist that does not operate. What I do is I utilize small procedures, injections, and things that are through the skin to help control chronic pain, to help diagnose the source of your pain, and to get you the longest relief possible without the need for long-term medications. So that's kind of where I come from and my focus. What I like to do is I'd like to bring up a little PowerPoint presentation that I have with a couple of slides just to kind of overview some of the things I offer. That's a little different and than most things that you think about when you're talking about chronic knee pain, chronic shoulder pain, neck pain, back pain, arthritis pain, nerve pain. There are many treatment options that are available, that are novel, that can help when other things have not. So interventional pain management, an option for treating chronic pain. I'd like to thank Boston Scientific, one of our companies that we use for some of their devices that help with chronic pain, and we're going to talk about some of those things as we move forward in this slideshow. So today we're going to talk about some treatment options for chronic pain, see what options may work best for your personal issues, certain things that we can specifically target, and some stuff that we can talk about if you decide to make an appointment. So there are certain types of pain. We have mechanical pain, which is stuff like arthritic pain, joint pains, muscular pains, when you have muscle spasm or your back goes out. Those things are mechanical pains. And then we have nerve pains, the things people say, I have sciatica, I have burning pain, tingling pain, numbness in my feet, issues where someone says, I lifted up a box and then all of a sudden I felt pain shooting down my leg, or I was in a car accident and I had pain shooting down my arm. Those are the things that are what we call neuropathic or nerve pain. And so when pain becomes chronic is when you've had pain for 3 months or longer. That's when we enter the world of chronic pain and we start trying to identify the different treatment options available to help break that pain cycle. So some of the things that patients complain about are being able to perform their regular activities in their household, their ability to do work with their occupations, playing with children and grandchildren, your normal recreational activities, something as simple as walking, going out for a hike, gardening, and then of course being sexually active. It's an important part of our lives, and there are many times where low back pain, nerve pain will inhibit these activities of daily living. So some patients you may or may not have tried some of these things, but the basic treatment protocols is to start off with simple anti-inflammatory medications like ibuprofen, Tylenols for analgesics, and then rest, right? So somebody sprains their ankle, ice, elevate, heat, see how it goes. If things continue to progress, your doctor or even myself may prescribe physical therapy. It depends on where you are in your treatment for whatever injury you have. There are modalities like TENS units, which is a stimulator device that massages the muscles electrically and can block the pain. That goes on the skin like little stickers. There are opioids for chronic pain, something that is a last resort, but in some practices and in some in the situation of some patients, doctors may not know about the treatment options we're about to discuss, or they may not have been available to you at the time that your medications were started. And so there are ways to get off of opioids using interventional treatments. But for me in my practice, I focus on utilizing all rehabilitation and interventions first, and then medications that are non-addictive before ever considering starting opioids. And we'll talk about some of those treatment options. There are drug pumps. That's a whole nother conversation. That's a different story. It's kind of a long talk, but essentially it's a delivery system that goes in the spine and provides opioid analgesics. That's something that some people may have had. And then surgeries, which is very common. People have joint replacements. They have lumbar spinal fusions where they remove discs and remove bones and fuse the back or neck, which is very common. And some patients continue to have pain afterwards, maybe different than the pain that you had when you started your treatment, but nevertheless still pain. And this is where interventional treatments can help. And then nerve blocks and nerves for the lower extremities, in the back and in the neck. These things you may or may not have had, and they're temporary. They can last for months or weeks, but it can easily wear off. And that brings us to two separate options here. We're talking about a couple of interesting things: radio frequency ablation and spinal cord stimulation. First, we could talk about spinal cord stimulation. Spinal cord stimulation is an interesting modality. If you've had surgery in your back or your neck, and you continue to have chronic nerve pain, something that can help with that is a spinal cord stimulator device, which is essentially a trial where we put a little wire in the back and block the pain electrically. And if it works for you and you're improved about 50% or more, it may be an option for a permanent implant to block the pain continuously for years. And there are many diagnoses that can benefit from this type of treatment, and that's post-surgery in the back, post-surgery in the neck, chronic nerve impingement in your legs or your arms. And the candidates for this are people who've tried everything and then could potentially utilize this treatment. I'm going to go back a second and kind of discuss radiofrequency ablation. When we're talking about the low back and in the spine, there are areas of the spine that can cause pain. And what we try to do as interventionists is identify where in this is your pain coming from. Sometimes it's coming from the joints in the low back and connected by these nerves that live in the low back here. Sometimes it's caused by the discs themselves pushing on the nerves in the low back. And occasionally there's this really large joint called your sacroiliac joint, which is another cause of low back pain. And this may be something that's unfamiliar to most patients, because when they say I have back pain, they say, oh, take some anti-inflammatories, have some rest, or you have sciatica. But it could be in any number of areas in your back that could cause your pain. And so by utilizing these treatments, they're both diagnostic by putting some numbing medication in certain areas and identifying that is where your pain is coming from, and then providing a treatment that can provide months of relief. So one of those things is radiofrequency ablation. And what we do is we block the joints. And if you get relief, but it doesn't last, then what we can do is we know that that area is where your pain is coming from. We can shut down those nerves for 9 months to 1 year. And so that's one of the tools that we have from an interventional perspective to control chronic low back and leg pain. And then several things that you may have heard of already are epidural injections, where we put anti-inflammatory medication around the nerves. All those treatment options we utilize first before considering doing something like spinal cord stimulation or peripheral nerve stimulation. And those treatment modalities could potentially get you years of relief without the need for a major surgery. And the beauty of these things is they are repeatable and reversible in many instances. So I just want to bounce back to my slideshow one more time. I think we've covered a lot of the topics that I wanted to discuss. And just let you guys know that these modalities, specifically spinal cord stimulation, other targets of nerve stimulation, can reduce patients' pain by a significant amount for up to 2 years, longer than 2 years at the outset of this treatment modality. So with that, I'd like to say thank you very much, and I'd like to open up for questions from our viewers if there's anything specific you guys wanted to talk about.
The next question is, could some of treatments you offer assist with fibromyalgia?
Absolutely. So I didn't mention specifically fibromyalgia as a chronic pain syndrome, but yes, fibromyalgia historically is very difficult to treat, as you know. So fibromyalgia is a diagnosis, what we call, of exclusion. We try to see what is going on. We run tests. Your primary care doctor or rheumatologist may have tested for other conditions that could potentially cause this generalized muscular pain. What I would like to do, if I were to see you in the office, some of the things that we would discuss are, have we checked several different conditions that could cause your fibromyalgia that could be treatable? That's one. Two, from an interventional perspective, identify and see if potentially you have arthritic and muscular pain. You have arthritic and low back pain, that it's not just fibromyalgia. You could have things like trigger point injections, which is something very basic. Medial branch blocks in the neck and low back could potentially reduce your pain significantly, greater than 50% or more for months. And if not, radiofrequency ablation could help with that as well. I have many patients with fibromyalgia that we utilize interventions that help them have a better quality of life and improve their function without utilizing medications like gabapentin and Lyrica. And in some situations, those medications are not helping. So yes, fibromyalgia is something that I actually enjoy treating, and I've had a lot of success. And a few patients that I've seen with diagnoses of fibromyalgia actually don't have fibromyalgia at all. They have something else, and it just was never evaluated from the perspective of a physiatrist or an interventionist. So yes, fibromyalgia can be helped with a lot of these treatment options.
Thank you. We now have another caller. I'm sorry, another question. How do I know if I need an epidural or a medial branch block or an ablation for my chronic pain?
So yes, so we didn't talk about this. So there's a workup that we're going to do if you were to come to the office. The way I treat my patients is I listen to them. That's the first and most important thing, because everybody describes their pain a certain way. Certain pain patterns and descriptions lead us to where it's coming from. Is it the joint? Is it the nerve? Is it something that could be ablated? What is going on, right? And we can do those things for the knee, shoulder, back, feet as well. I do my physical exam. That gives me another clue. And then I utilize imaging and tests to see where this pain is coming from. Because like I mentioned earlier, there are a lot of areas of the back that can cause a lot of pain generators in the back: joints, ligaments, tendons, muscles, nerves. And so an MRI, an X-ray, or a nerve conduction study can help pinpoint and focal and target where that pain is coming from. And so my rule of thumb is 2 out of 3 of those things come together, well, then that's possibly the area of your pain, and then we can target that with potent medication to diagnose and treat that condition, providing you with long-term pain relief.
A question came in from Mary. Are there any new treatments or medications for hypnic headaches?
Specific hypnic headache specifically?
HYPNIC.
So depending on the type of headache syndrome, there are different treatment options. From an interventional perspective for headache, a lot of the things that I provide are diagnostic blocks, diagnostic third occipital nerve blocks, and then radio frequencies of those procedures, greater occipital nerve blocks, and lesser occipital nerve blocks. There are some atypical sphenopalatine blocks that can treat atypical face pain and headache. It depends. Headache is a very complicated diagnosis, and depending on your diagnosis of hypnic headache or migraine or cluster, there's a whole wide range. Headache specialists specifically are more attuned at providing medications for those things. So if you were to be seeing somebody, a neurologist or a headache specialist, and they've exhausted all options for you from their perspective, I'd be glad to see you in the office and give a different approach and take a look and see what's going on with your headache syndrome specifically. So to tell you the specifics of hypnic headache, this medication, it's more of maybe we should assess you from a different perspective and see if there's something that we can help with your headache syndrome. But if you're already seeing a headache specialist, I think that's the best place for you to be. Many times when I was in fellowship training, I trained at Montefiore Medical Center, and on the same floor as the interventional clinic was the headache clinic, and we collaborated with each other very closely. Many times when they needed interventions, they would refer to us, and we would take a look at the spine and see if there was some generator there that was contributing to your headache pain. And then when things were less focal and targeted and more central nervous system mediated with the brain, then we would refer to the headache clinic. But we work together. And that actually brings me to a good point. My practice is multidisciplinary. I don't just take everybody in here and say, okay, this is what we're going to do with an intervention. You may get a referral to neurology. You may get a referral to rheumatology. You may get a referral to see an orthopedist, because good pain care is comprehensive, it's holistic, and it's personalized. And in today's world, with the opiate epidemic, with the fragmentation of healthcare as far as finding a pain specialist, the fact that people with chronic conditions have not seen a pain specialist is a problem. And that's what we're trying to promote and spread the word that we're here and we all work together. So from the headache perspective, I think it's worth a discussion.
Someone wrote in, I have pins and needles in my right hand, and sometimes my hand feels numb. This has been happening throughout the summer until now. I guess what should she do, or how could she approach that?
So there's a lot of reasons why a person could have pins and needles in their hand, and it warrants further evaluation because it could be a number of different things. It could be simple as carpal tunnel syndrome. It could be a problem with the nerves in the arm, the neck, or even the brain. It's potentially an issue. And it depends on what workup has been done already. But if I were to see you in the office, we would take a look and make sure that there were no major issues like major arm weakness, memory loss, dropping of objects. And the workup would probably consist of a EMG, electrodiagnostics, getting an MRI of the neck, and then a physical exam to see where this is coming from. It could be coming from your median nerve. It could be coming from a nerve in your elbow. It could just be muscular pain that mimics that tingly sensation. It really depends on what it is, and without the proper information of your age, your demographics, your previous health history, a full medical workup, it's hard to say specifically, but my recommendation would be, at least, if you don't see me, go see your primary care doctor and let them check you out if you haven't seen somebody already to make sure everything is okay.
Okay, Evelyn wrote back, I guess she's having discomfort when she's sleeping and is frequently behind the knee.
So yeah, it's when we go to sleep at night. The interesting thing about pain is that it's all just signals coming from our body. It's electrical signals getting to the brain like a computer, and it has to be processed, okay? When we go to bed at night, we have no competing stimulation other than what our body is naturally telling us. So when I'm talking to you now, I'm looking at the computer camera, I'm seeing the lights in the room, I'm moving my arms around, my brain is doing a lot of stuff. And then when we go to bed at night and we lay down, everything calms down. And the only thing we start to hear is the pain. So specifically what's happening behind the knee, it could be a number of things. It could be arthritis. It could be a ligament strain. If it's tingly or burning or something like that, it could be a nerve pain from your back. It depends. Now, does it come down the leg from the back to the knee? It could be some sort of nerve issue. So there's a lot of different reasons to have this. And from an orthopedic standpoint, there's unique things, and I saw one today, a flabella, which is a little bone in the back of the knee that could cause irritation. I don't think that's what you have, I don't know. But what I would say is if that's something that's really bothering you, we can look at it with an ultrasound, look at it with an x-ray, look at it with an MRI. I do ultrasound guided procedures in the office, so I can scan it, take a look at your knee. You may have a Baker's cyst, which is just a degenerative arthritic change and some swelling in the knee, and in the back of the knee you just feel that pressure. There's so many options that it could be, and there are many treatment options that we could provide. So if you'd like, make an appointment. I'd love to see you and take care of you.
Thank you for answering that. The next one from Gina. Can you do anything for tinnitus?
So tinnitus, ringing in the ears. So there is some evidence to say that certain nerve blocks behind the head can alter tinnitus. There's actually, the research was done at my institution and Montefiore prior to my training, but I know the doctors that trained me published the paper. That cervical medial branch blocks, third occipital nerve blocks, can alter the sensation of tinnitus. It also depends on what's going on in your ear and why you have the tinnitus, because it is an abnormal sensory stimulation, and the literature is complicated as to whether it's coming centrally from the brain or coming from some irritation in the inner ear. There are some modalities, manual therapies, which I actually didn't touch on. I'm an osteopathic physician that also can do some manual therapy for the neck and back. It's a secondary modality that I also use to treat patients. And there are some manual therapies that can be done to the inner ear to help calm down tinnitus. So yes, there are a couple of different options. If you've exhausted all the medications, the nortriptylines, the antidepressants, the cognitive behavioral therapies, if you haven't heard of that, that's something that I might refer you to, which is a form of therapy, kind of like physical therapy, but for chronic pain to help you gain control over those abnormal sensations. And I have a place that we refer patients to get that specific treatment. So that was actually a good point with the tinnitus. Tinnitus is something, again, that needs multi-specialty care, but we do have interventions that can help. So yes, there's a couple of different options. If some of the things I have said right now, you have not tried, it may be beneficial to stop by and get a consultation. If you've tried all of them, well, that's kind of what we have as far as for tinnitus.
Another question's come in. I've had shoulder surgery and I'm still in pain. What are my options?
So there are several options for chronic shoulder pain. So depending on the surgery that you've had, if you had a rotator cuff repair and you continue to have pain, if you had a capsular release and you still have pain, or if you've had a total rotator shoulder replacement, completely replaced and you still have pain. There are several things. First, some of the things you may have already utilized are ultrasound guided joint injection, which, depending on where your pain is coming from, and you still have a joint and you don't have a total replacement, we could inject the joint. You could inject the AC joint, which is an anterior portion of a joint here. It's a smaller one. Sometimes causes pain when you bring your arm over like this. It hurts right in the front. Or when you move your arm down, your tendons may still be inflamed, and we can do a tendon injection. Now, there's a nerve that connects the shoulder, and sometimes it gets irritated or injured during or after a surgery and has some sort of long-term pain. So we can inject some numbing medication around the nerve, your suprascapular nerve, or your axillary nerve, and block the pain in the shoulder. And there's a newer treatment modality, which if you've trialed those other things and you've had surgery, and nothing has been helping, including physical therapy and medications, we have something called a peripheral nerve stimulator. It's something that is very small. It's like the size of a hair, strand of a hair. And we place it right over that little nerve and use electrical stimulation to block the pain. The beauty of this procedure is that it is temporary, so it's a singular treatment. It is removed, there is no surgery required, and we do it all with an ultrasound and one small needle in that spot. And you get a remote control to stop the pain, and it stays in for 60 days. During that time, your pain gets less and less and less and less. And when it's removed, the research shows that patients have sustained relief for up to and over a year. They have reduction in the pain, improvement in their function, and in some instances, even if you're on opioids, there was a reduction in 50% use in opiates. So if you're one patient that relies on these medications for chronic post-surgical shoulder pain, chronic post-surgical knee pain, and back pain, which is all these things are used for, you could have a reduction in your need to take opiates. This treatment, I've done several cases in the past few months. Everybody is doing better with reductions in 50% to 100% pain relief post-shoulder pain, post-total replacement surgery. They're all doing very well, and I'm hopeful that it continues to last. I rarely say I get 100% pain relief. I try to set my expectations reasonably for my patients, that we would like to get at least 50% and some improvement. I love to see more, and sometimes I do get 100%. But with this last treatment, I can honestly say I have a patient who has had pain for years and now has no pain. And so I'm very excited about this new modality. I'm one of two doctors in Westchester County to Albany as of right now that are providing this treatment modality. So you can go into the city to find someone, but currently in Yonkers, Westchester County to Albany, there's only two of us, and I'm one of them, and it's a great treatment option. I'm actually, well, I shouldn't say this, it's a HIPAA, but I'm treating my family, and I'm helping them with this treatment modality, so I'm very excited about it.
This is kind of along the same lines. I've had hip pain and tried PT, which helped a little, but I'm too young, or I'm too young for surgery. What are good options for me?
So the hip is an interesting joint. There's the hip socket where the people say they have arthritis. There's the outside of the hip where you have some what we call bursitis, or inflammation of tendons on the outside of the hip. And then the back of the hip in your buttock area can refer pain into your hip. And it could be, it's called your sacroiliac joint. It depends on where it's coming from. But the short answer is we can put an injection into the hip joint itself under X-ray guidance. Guide the needle, a little bit of numbing medication right into the spot, put a little dye to make sure we're inside the spot, because the hip is a thick joint. And when you do not do it under X-ray guidance, you can miss. And the literature shows that. People miss all the time, even with an ultrasound. So we do it under X-ray, put some medication inside the hip, and hopefully we can get you sustained relief for several months. If you have to do them once or twice a year, it's very safe to put a little steroid injection into the hip and continue with your therapy to hopefully bridge you to your surgery. In addition, we have the sacroiliac joint as a target and the bursa, all different areas that could be causing that hip pain. In addition to areas in the spine, every once in a while, we'll find a patient that has arthritis in the low back, and that L4, L5 joint, that little nerve in the lowest part of the back, is referring pain into the groin. And by blocking it and ablating it, we can get rid of hip pain. And so it depends. So those are the options. I would say simply if you have arthritis in the hip, and that's what we're talking about, put a little medicine in the hip and see how long it helps, and we'll move from there. There are many options after that as well.
Okay, and this will be our last question. Dr. Rose, if someone wanted to make an appointment, what would they need to bring with them to the visit?
Oh, excellent question. In order to expedite your care, in order to get you the treatment that you need as fast as possible, I would need to see any of your previous MRIs, previous X-rays, previous nerve tests or nerve studies that were done from your other doctors, and any procedures, surgeries, or injections, because having all that information together will allow us to move to the next step. If I don't have an MRI, and specifically if I don't have a disc. Now, if you've had your MRI done at St. John's, I have access. If you had your MRI done at several areas in the community, I have access to many of those. But if you bring the disc, we definitely will be able to review it, because I read all my own images. I don't rely on radiology reports. So before I go ahead and put a needle around your spine, in your shoulder, in your neck, your low back, if I'm going to do a procedure there, I need to know the lay of the land and where I'm going to go, so it's safe for you and safe for me and easy for everybody to give you the best experience possible. If you're missing any of those documents, if you're missing any of that stuff, well, then our first visit will consist of doing the exam, coming up with potential treatment options, but until I get that imaging or those previous records, we're not going to be able to get you scheduled. So it's just easier all around to limit the amount of visits that you have to come back and forth to the office or to the hospital to get things done. But yeah, so previous records, previous images, and that's it. And if I could do something for you in the office, we will try. If you need to do a procedure, we may have to schedule you at the hospital for a procedure in the hospital, depending on what it is. But that's what to expect on a visit.
Thank you so much. That was such great information and great questions. Thank you, Dr. Erosa, for joining us today. And to our partners at Yonkers North and Yonkers Public Library, we are going to wrap up our webinar for today. But if you found this presentation helpful, you can find it on Facebook. We have recorded it, and you can pass it on to your friends and family. We will also have one more webinar next week on October 29th on stroke awareness and what you need to know. So I hope you can join us. We will also be leaving you with Dr. Erosa's contact information if you would like to call him and ask more questions or make an appointment. Thank you again for joining us, and have a great evening.